Welcome everyone to Revolutionizing Colorectal Cancer Management with MRD Insights, being organized by Voice of Healthcare and supported by Zydus and Guardant Health. Colorectal cancer remains a significant global health challenge. Early detection and precise management is very crucial to improving patient outcomes. Minimal residual disease, that is MRD, testing is transforming colorectal cancer management, allowing us to detect microscopic cancer cells that may remain after treatment. With advancements in liquid biopsy, MRD testing offers a powerful tool for predicting recurrence, guiding treatment decisions, and personalizing patient care. Today, our expert panel will explore how MRD is reshaping colorectal cancer monitoring, its real world application, and the challenges that remain. To discuss this, we have with us today Dr. Niti Raizada, Principal Director, Medical Oncology, Fortis Healthcare, BG Road, Bengaluru. Welcome, ma'am.
Thanks so much.
Dr. Vaibhav Choudhary, Consultant Medical Oncology, Kokilaben, Dhirubhai Ambani Hospital and Medical Research Center, Mumbai. Welcome, Dr. Vaibhav.
Thank you.
Dr. Priya Tiwari, Head Medical Oncology, Artemis Hospital, Gurgaon. Welcome, Dr. Priya.
Thank you. Hello, everybody.
Dr. Palanki, Chief Medical Oncology, Renova Hospital, Hyderabad.
Hello,
Welcome, Doctor.
madam. Hello, everyone.
So I welcome you all. And to start with, my first question goes to Dr. Niti. So, Dr. Niti, can you tell us that what colorectal cancer is, what are its different stages, and how are we managing early stage colorectal cancer nowadays?
So, thanks so much for inviting me, Dr. Manisha and Voice of Health. Well, how colorectal cancer is cancer of the colon and the rectum. Colon is a large intestine, and the last part of which is rectum, which collects the stool before it passes through the anus. So, colorectal is a spectrum of cancer in this part of the body. How do we manage? Well, firstly, if we have a patient who comes with either bleeding, anemia, or anything which points bowel disturbance, which points towards a colonic or a rectal malignancy, first thing is we have to do a scopy. That could be a sigmoidoscopy or a colonoscopy, and then take a biopsy to confirm whether it is cancer. Now what has changed is after doing a colonoscopy, the biopsy is sent for histopathology, but we also do certain molecular markers at baseline, which includes MMR or MSI and sometimes other markers. And then, of course, we do a stage to determine where all is the cancer, whether it is localized in the colon and rectum, or it has gone to any other part like lymph nodes, or it has gone to the liver, lung, or any other part. Based on this, we stage the cancer. It is stage 1, stage 2, stage 3, or stage 4. Limited to the colon, locoregional disease including lymph nodes, or it is spread to other organs. Based on that, we would choose to do surgery for early cancers. We would treat with surgery followed by chemotherapy or sometimes immunotherapy in locally advanced cancers. And when it is a metastatic disease, stage 4 disease, which has gone to other parts, we'll try to do a molecular profiling to see what is the expression of tumor and then give chemotherapy along with biologics or sometimes immunotherapy. This is what we would normally do. And then once the treatment is over, we put all these patients on surveillance. So we put it on follow up. And follow up depends again on the stage, which could be a scan based follow up or a serial CEA, which is done as follow up. Or we sometimes do other things like MRDs, which is also the topic of discussion today.
Correct, ma'am. So that is very concisely you have told us that how we are monitoring, how we are managing, especially the early stage cancer. So since the topic is minimal residual disease, that is MRD. So my next question goes to Dr. Palanki that what is minimal residual disease and why is it important, especially in colorectal cancer?
So, MRD or a minimal residual disease implies those small amounts of cancer cells at the microscopic level, which right now can't be identified by routine investigations or by some investigations like CT scans or MRIs or PET scans. So these scans or routine investigations can't identify these microscopic residual tumor cells, but we all know that there could be some amount of MRD despite initial treatment, which can be surgery and or chemotherapy and or radiation therapy or different combinations of these treatments. So, minimal residual disease implies a small amount of residual disease at the microscopic level, which can be identified by special tests which can look at these MRD cells. It's important because it helps us to identify patients who might be at a higher risk of recurrence. And so, if you can identify MRD early, we have a chance to intervene before the disease comes back at a macroscopic level. So, identifying disease early at a microscopic level helps us to understand the disease biology, respond and react appropriately to that, so that we have a chance to prevent the disease from coming back by doing some interventions which will depend on the type of the disease and the cells or the amount of the DNA load which we may find on the MRD testing. And so, intervening at a microscopic level prevents the disease coming back at a gross or macroscopic level when we plan to do some interventions to address the minimal residual disease.
Right, sir. So basically, minimal residual disease is addressing the microscopic level so that it should not turn into gross level or macroscopic level. And this is a kind of early detection and early intervention. Right, sir. So, Dr. Priya, how is MRD detected and how does it is compared to the traditional method like the blood test, or the scans? Please unmute yourself, ma'am.
Okay, so I was saying that first of all, thank you. It's a very nice topic to talk about. So MRD detection we can do by two methods. First of all is that you have treated a patient for cancer and you find out what were the mutations or the genetic changes in that particular cancer patient. For that, you require a tissue sample, and then following that, you make a tumor DNA signature, and then later on you try to detect that in the blood to see if there is some lingering cancer in the blood. That is one way of doing it. The second way is, especially if you don't have an access to tissue of the patient of the tumor, so you try to find out what. So we have a lot of information about cancers these days. So combining all of them together, you try to see that by the ultra sensitive method that what could be the particular mutations and the circulating DNA in the blood of the patient, and that is, I think, it's more commonly being done. So these are the two methods by which you can detect the microscopic levels. That is what the MRD has already explained in the blood, or what we call as the liquid biopsy. So this is the liquid biopsy that we do, because by liquid we mean is being done in the blood. Now, because they are very sensitive methods, so we know that the scan might pick up the disease recurrences late or any residual disease. And we also know that sometimes CEA, carcinoembryonic antigen, might not be sensitive enough, or there are certain group of patients where we actually don't see any CEA in spite of them having a lot of disease. So wherever the CEA is not the marker, and at the same time, it is much more sensitive test than the CA or the scans. So it can pick up the disease earlier as well. So it's more sensitive than the traditional methods. And yes, there are two methods that I just explained to detect MRD.
Right. Right. So liquid biopsy is helping us to address
Yes.
this at the microscopic level, and definitely they are performing better than the blood tests and the scans, which are the traditional method of picking up the disease. Right. So my next question goes to Dr. Vaibhav. When should MRD testing be done, and how often should patient undergo testing?
Yeah, very, very good question, very relevant also, because now it has been offered mostly as a routine care in most of the scenarios now in colorectal cancer. It has been standardized to a great extent. So now the best time to do MRD would be post-surgery. Once we get rid of the tumor, do a complete surgery, and after that, typically 3 to 6 weeks or 4 to 6 weeks after the surgery, to find out whether some residual tumor cells are there in the body, lurking around here and there. And then these are the cells basically which sit in lung, liver, or other organs, and then give rise to stage 4 disease. So by the time these things happen, ultimately the disease becomes incurable and becomes stage 4, despite doing a curative surgery. So the best time to start is post surgery. After that, if you do detect some minimal residual disease cells, some tumor CTC, ctDNA is there, and then you work around that. If it is positive at the baseline, then it is implicating two things, that it is a high risk tumor and it definitely would require more than just surgery. That would be adjuvant chemotherapy, or maybe in some instances now world is progressing towards other modalities as well. So after intensifying treatment, if you find the first one that is positive, then subsequently every 3 to 6 monthly, as a routine follow-up, you have to do MRD to see whether those residual tumor cells are cleared of blood or not. Remember, first of all, at the baseline, if MRD is present, if tumor cells are present post surgery, it's not a great prognostic marker. That does mean that you need more. It is kind of a predictive marker. You can say that it will require more treatment. And subsequently, if patient is on treatment, has finished adjuvant therapy, then also the clearance of MRD is also very important. That again, those if those cells become undetectable after adjuvant therapy, after adjuvant chemotherapy, then again it's a good sign. If they remain, then again it heralds a poor prognostic factor. So depending upon risk factor, depending upon the tumor types, this interval of checking MRD would be 3 to 6 months somewhere.
Right. So monitoring is done every 3 to 6 months. That's correct, sir. So, Dr. Niti, how accurate is MRD testing using the circulating tumor cell DNA, and can it reliably, predict cancer recurrence?
So, Manisha, this is a very, it's a very tricky question because MRD is tested by checking the circulating tumor DNA. Most important thing is standardization of the test. It has to be in the right place, which is validated. And the second important thing is whether it is interpreted correctly. So there should be a good team, there should be good scientific officers or good interpretation systems to understand these. But otherwise, MRD done from the right place is an extremely useful tool. It is an extremely useful tool to find out who are the molecular responders and who are the patients who are early molecular relapsers. So if they relapse early, then you have to kind of close the gap by adding extra treatment. So yes, it's an extremely good test if done in the right place with the right platform.
Right. So, Dr. Palanki, can you tell us that what happens if MRD is positive? Does it mean that the tumor is definitely going to come back?
When the test is ordered and the report comes back, you will have in the report either MRD positive or MRD negative. An MRD negative report means that there is no evidence of any minimal residual disease, which becomes reassuring. On the other hand, if the MRD is positive, it tells us that there are still some residual cancer cells in the body at the minimal level or the microscopic level. And this portends and tells us that there could be increased risk of recurrence. Now, increased risk of recurrence does not mean that cancer will definitely return. It actually tells us and guides us in deciding the next steps. For example, we look at the patient and do a more close follow up of some investigations, which means more careful monitoring of the disease. Or sometimes you might want to give additional cycles of chemotherapy, or you might want to change your chemotherapy, or if you have a clinical trial available, then we all know that one of the best ways to manage patients with MRD is to enroll them in clinical trials looking at these minimal residual disease. With the kind of networking we doctors and the oncology colleagues today we are able to know at which center, which clinical trials are available to enroll our patients to get the best possible outcome in that particular situation for that given patient for that particular cancer. So either we closely follow up the patient, or we give some additional treatments or change treatments, or we enroll them in some of the clinical trials looking at MRD, because as we all know, the future will depend on how the clinical trials which randomize patients ultimately tell us what is better and what is better than the best currently available. The key benefit of MRD testing, therefore, is it allows us to act early, and this will help us to improve treatment outcomes and patient cure rates. So potentially, we intend to treat more patients more appropriately at the appropriate time to get the maximal benefit from the available treatment options by identifying disease at a microscopic level, because that's the right time when treatments are most effective. Thank you so much.
Right. So in a way, it is guiding us to, choose the therapy and personalize the treatment. Right. So Dr. Priya, what happens if MRD is negative? Does that mean that patient is fully cured?
So it's see, the problem is cancer is a very dynamic process. Okay, if an MRD is negative now, that of course is reassuring, but does not mean that it can't become positive later. Okay, so it's always an MRD negative is always a good news for everybody, for the doctors, for the patient. But we know that the patient will require continued follow up because there is a possibility that it might become positive in the future.
Right. Dr. Vaibhav, we have been talking about MRD testing and the liquid biopsy and detecting at the microscopic level. I would like to know that what are the present challenges, what are the limitation of these tests?
Yeah, it's quite impressive the data which is coming in, and with the sophistication of technology, we are now refining this test more and more to the extent that now authorities are also given approvals in certain settings, and it is now becoming kind of a very standard test. But despite all this, there is still room for increasing the sensitivity of the test, because as the previous speaker already told that sometimes at baseline MRD is negative, then it becomes positive on subsequent follow-up. Now, from where did this cell come from? These are already there. And then those cells actually, we need a more sensitive test to 100% detect at whatever lower molecular level these cells are. And we are working in that direction. With every passing day and the research which is coming in, we are getting there to the extent that our MRD false negative rate should come down, and it has come down to an extent that it is now practically usable. So that is the thing where scope for improvement is there, that will always be there, so that this thing of negative early and turning positive later should be actually completely gone, to be saying that it has become a gold standard. That's where I see that's the biggest limitation. That's one thing. Second is, with the new technology, whatever new things come, uh, for example, if a new cell phone also comes, it is very costly, these foldables and all, right? The more time it spends, more refined it gets, then the cost comes down and the access also increases. The same thing is with medicine, same thing is all these tests, sophisticated tests as well. So cost, yes, cost and access still remains an issue in a country like ours, where it's a big country. A lot of people afford it, a lot of people have access to it. But still, if we can work on it, considering the volume and the burden, that scope is still there. That the cost as well as access needs to be. These two things are there. First, sensitivity, that you should be sure that it is the gold standard, and second, that cost, and that will eventually come down with what, for example, when NGS started some 30 years back, it was like it used to call was a huge amount. Now NGS are being done at a very reasonable cost. So similar level of standardization, sophistication, it does come down, the cost does come down, and the access subsequently improves. And also with the ongoing research, the subsequently this problem of false negativity will also go away. So these things are there, but all said and done, MRD, at least in colorectal cancer, is now for prime time use.
So standardization of tests and bringing the cost down, that remains the challenge. Right. So Dr. Niti, can you tell us that how can, with the help of MRD, we can integrate, the patient into clinical trial and use some experimental drug and personalize the treatment?
We are moving in the era of personalized care for everything, Dr. Manisha, any cancer. And of course, CTDN is an important tool when we look at doing personalized care. And we know that now it is molecular directed therapy by using next generation sequencing platform. And MRD in colorectal cancer, as everybody mentioned, is now even in our guidelines. It is slowly getting up the ladder, and we have been using these practices in routine wherever feasible, based on what test we use, whether it's a standardized and validated test, and of course, as I said, the right interpretation. And of course, in resource poor settings, we have to also know the challenges of cost, but wherever possible, immediately after surgery, where it can be done as a monitoring, especially in stage 2, and of course wherever possible in stage 1 as well, to find out the people who are complete responders, molecular responders, and the patients who immediately after surgery at 4 to 6 weeks, when we do and there's still a residual disease, then we would want to add adjuvant therapy. We would want to titrate therapy to intensify it in future. This is what we do. And of course, it has applications in metastatic setting as well, advanced cancer, where we do monitoring of one mutation. It could just be a KRAS monitoring, where we see whether it has responded to therapy or not, whether the values have come down or come up, or other mutations which are analyzed at the time of metastasis, when it responds, and when there's an early relapse.
Dr. Priya, what role does artificial intelligence like machine learning is playing in MRD testing? Do you
So I
believe
think
that it is playing?
so all the data analysis is actually being done by the AI. So what's coming is there's a humongous amount of data which is generated, and we need the final answers. So AI is helping there. The analysis part is actually a lot dependent on AI. Now, what is also is happening is that the labs are bringing in more and more AI-based sophisticated tools, not just in analysis, but also how the data is collected. Okay, so how is data is collected and fed in the system and analyzed, all is being done by AI. So yes, artificial intelligence plays a very important role.
Yeah. So it is basically the data analysis, right? So, Dr. Palanki, can you tell us that we have been talking about immunotherapy and the chemotherapy, treatment decisions. How can MRD help us guide treatment decisions, such as to choose between immunotherapy and chemotherapy?
The dream of medical oncologist comes true when he'll be able to offer a tailored treatment for that particular patient. And this is the era of precision oncology, or precision medicine, where we precisely identify that patient's tumor, identify the abnormalities in that tumor, and then try to specifically target those driver mutations which are driving the disease. And so, when you have MRD positive, which is showing the circulating tumor DNA or ctDNA in the peripheral blood sample, now that DNA can be analyzed to look at all the genomic aberrations which are present in the circulating tumor DNA, which is a reflection of the primary tumor or the metastatic secondary disease sites. And that helps us to choose the right treatment options. So, for example, targeted therapies target those specific driver mutations found inside those cancer cells. Similarly, for immunotherapy also, we have various biomarkers which tell us that these are the patients who benefit from the immunotherapy. So gone are the days when we talk about empirically choosing chemotherapy or chemotherapy combinations, and the current era and the future of medical oncology will be targeting that particular patient's cancer, which has those specific genomic aberrations which you identify on the primary tumor or by doing a liquid biopsy in the circulating tumor DNA. So the
Right.
field is rapidly evolving. Medical oncology is a hugely and heavily evidence-based oncology practice. And that's why various randomized clinical trials are being done to find out that we are not experimenting on our patient clinic, but rather randomized clinical trials are guiding us to choose the appropriate treatment options so that we have against the cancer maximal efficacy and to the patient minimal toxicity. That is the goal of every cancer specialist. Maximal efficacy against the cancer and to the patient minimal toxicity. In a way, MRD is guiding us and making us move in that direction very fast.
Right. So to minimize the side effects and to have the tailored treatment. Correct, sir. So, Dr. Vaibhav, while we have been talking about the treatment of colorectal cancer, I would like to ask you that does lifestyle factor like diet, smoking, alcohol play role in colorectal development, cancer development, and progression? And if yes, can we do something to modify it?
Cancer, in essence, is a lifestyle disease. The hereditary part of cancer is being heavily overrated. But most of the cancers are environmental. Environmental means acquired mutations which occur and lead to cancer. So yes, colon being a part of our gastrointestinal system, it is exposed to whatever, directly exposed to whatever we eat or drink or those things. So here actually the diet and alcohol even, they play a very significant role. For example, it has been known for ages now that red meat ingestion, that is itself is a risk factor. Another thing is those, obviously, if you don't maintain a healthy lifestyle, there will be obesity, and there have been studies since long to point out that obesity itself is a risk factor for colorectal cancer. So there are obviously everything is environmental, but it's not a one single factor which is leading towards. It's not that simple. Multiple factors are at play. What is in our, some are modifiable, some are non-modifiable. So what is in our hands, we can actually look at that. We can cut down the ingestion of red meat or alcohol. We can adopt a healthy lifestyle involving exercise, daily exercise, mild exercise, maintaining a healthy weight for a body type, having a good fiber content or fruits in our diet. So there is not one single thing, but a compilation of a healthy lifestyle, which will give us the best chance to avoid this environmental factors and avoid colorectal cancer in majority of the patients. So yes, all these factors needs to be looked at it very seriously and modified, and we doctors ourselves should take the responsibility to clarify various doubts. Like there are many things, many theories going on, that some certain theories are baseless, that eating this or eating that would lead to cancer and would prevent from cancer. So there has been a hell lot of research in diets and cancer, because it's the simplest thing that a human mind can comprehend. But more factors are directly related to colorectal cancer, because here whatever you eat and all, basically diet especially plays a major role. It passes through colon, passes through rectum, and there is a lot of exposure there, which may lead to carcinogenesis. So yes, this is what we can do: adopting a healthy lifestyle, healthy diet, healthy weight, doing away from these carcinogens. This will help.
So, Dr. Priya, can you tell us some symptoms of colorectal cancer, and do you believe that liquid biopsy can help us in early detection of colorectal cancer?
So the symptoms are the colon cancer. So colon is something that is what we call as a large intestine. Okay, so as the stool passes through the large intestine, in the initial part it is more liquid, but over the course of its journey through the large intestine, it solidifies. So the symptoms will actually depend from where the tumor or the cancer is happening. Okay, so what we call as the left side of the intestine, large intestine, or the right side of the intestine. So as the cancer grows, when the stool is passing and when it tends to solidify, so we see a lot of constipation. Now we say the constipation is very common. Anybody above the 40 years, 50 years, constipation is quite common. And that is the reason that the cancers are often missed in the early stages, because the symptoms usually mimic the commonly occurring problems. Okay, so constipation is one of them. Also, sometimes there could be blood loss. So cancer could be in the form of ulcer, and the tumor can give rise to blood loss. So we see the blood in the stool, and that is why one of the screening tests will actually involve doing the blood test in the stool, what we call as the stool occult blood. Also, if there is a persistent loss, it can give rise to anemia, so low hemoglobin. So we traditionally say that anybody who has low hemoglobin should always be investigated for a colon cancer, or for that reason stomach cancer. So these are the two very important symptoms. But yes, if the cancer starts to grow, You can also have for fatigue, weight loss. There could be other systemic symptoms such as loss of appetite. And yes, if it is happening in a lower part, a very lower part of your large intestine, sometimes patient could have a growth, growth which can be felt. And yes, so sometimes there could be constipation, and sometimes there could be severe constipation. And yes, because if there is a growth which is obstructing the lumen completely, the content will start to get accumulated, and it can also give rise to perforation. So sometimes patients can actually come to the emergency saying this severe abdominal pain, and there could be hypotension. And when we do the examinations, we find that yes, the content of the intestine have perforated. If the cancer can actually metastasize, so we will see some kinds of symptoms related to the metastasis, such as if it has gone in the liver, we will see alterations. When we do the liver function test, we'll see alterations. And in the most severe cases, there could be jaundice. If it can go to the lungs, cancer has a problem of going to the different body organs. If it goes in the lung, there could be shortness of breath. So, and yes, sometimes if it goes in the bones, there could be bone pains also. So this is what it is. If we talk about the role of liquid biopsy, the MRD that we are talking about, see, we are trying to do the ultra sensitive methods for the cancer screening, and there are few FDA approved tests in this sphere also, but as such, they have yet not come into the guidelines. So when the cancer, we say that from the day one, it starts to release some DNA in the blood. So yes, there are ways to detect this DNA with the ultra sensitive methods. The one kind of test, all that we are talking in the MRD, is the other kind of test also. Like in a really asymptomatic patient, we can do certain these tests. Okay, so yes, there are tests available, but they are yet not approved by the guidelines as a part of the routine screening recommendation. So we are not doing it there. We are not yet there as far as the screening is concerned, but the tests are there. Yes.
All right. So, Dr. Niti, I would like to ask you some real world examples where you have been using liquid biopsy, how it has changed the journey of, the patient of colorectal cancer. If you could give us some examples.
So, Dr. Manisha, actually, what used to happen is, I think, in the past 1 decade, 1.5 decade, we would always have a metastatic colorectal cancer in which we would do certain important testing to decide what are the biologic therapy or what are the drugs that will be used. So, we used to do KRAS, NRAS, BRAF, and MSI. This was the standard which was done in all this years, 1.5 decade. But in the past few years, we have moved to NGS, that is broader based molecular panels. And also, why we do that? We look at the main mutations which will be there, but we also look at the downstream pathway or the pathways which could actually cause resistance to that mutation, and also certain rare mutations which require which can work in any tumor subtype. So now when we do broader based molecular profiling, we not just look for RAS, RAF, but we also look for MSI, POLY, POLD1, ultra mutations, tumor mutation burden. We look for tumor agnostic markers like RET, we look for NTRK, and then we of course look for HER2, which is again increasing its role in metastatic colorectal cancer. So basically what we do is we look for targetable mutations in which there are specific drugs, and we look for resistance pathway for the targetable mutation, whether there's a resistance pathway, and if we give that drug it will not work and therefore we should change the path. This is in frontline settings. Then when any patient actually has a metastatic disease which has not responded to the frontline, we try to add more, we try to get more data from not so conventional treatment. We give first line and second line treatment, which is conventional. But beyond that, there may be not many guidelines stating what we can do in third line and beyond settings. So when we get more information, we can again tailor make treatment or make it a very precise treatment, which will be very individualized for that patient. May not be very generalistic. Then we have to customize treatment, whether this will work for this particular patient or not. And then we get more molecular information. We sit together in molecular tumor boards. We sit together, all of us sit together and decide what are the pathways which may work in one particular individual to maximize results. Because initially patient is nutritionally fit, overall fitness makes us give more stronger treatment. But later down in the line, patient's fitness is compromised. Also, patient's morale is compromised. In that point in time, whatever is the best should be very decided in a very specific way with good rationale, taking everybody's inputs, including molecular biologist input, whether any other path could be directed so that we can get good results out of it.
Right. So, Dr. Palanki, can you tell us that what are the survival rates in different stages of colorectal cancer, and have you been using MRD testing, and how has it improved the survival rate of your patients?
I think as oncologists, all of us try to educate our patients, and also we talk in various platforms about cancer is curable if detected early and then if treated appropriately. So, if you have a stage 1 colon cancer, then the cure rates are in excess of 90-95% with conventional treatment. Stage 2 colon cancer, the cure rates are in excess of 80 to 85%. So, more than 85% of patients get cured with stage 2 colon cancer, and more than 95% or 90% is stage 1 colon cancer. Once it comes to stage 3, then the disease has gone beyond the confines of the colon to involve some regional lymph nodes, and therefore the cure rates come down to 65% with surgery only, but by giving additional chemotherapies, sometimes 3 months, sometimes 6 months, the cure rates go beyond 75%. Now, in stage 4 colon cancer, there was a time when we used to say that stage 4 means it's the end of life and you're counting days or weeks or months. But now, even in stage 4 colon cancer, and for that matter, rectal cancer too, despite the patient having liver metastasis, the aggressive treatments, including the use of targeted therapies, we are able to not only operate and resect the primary tumor from where the cancer arose, but also operate upon the liver metastasis, and ultimately the patient doesn't have any evidence of cancer at all. So even in stage 4 too, there are a significant proportion of patients who stand to benefit from aggressive interventions. And mainly the role of MRD comes in those situations where the follow-up becomes very important for us to know if we have been able to remove all the disease. And if that's the case, then is there any MRD present or not? If MRD is absent, that becomes very reassuring, but then we use it at regular intervals. Say, for example, the first test is done now, MRD is negative, and then you do after, say, 3 to 4 months, and again do after, say, 9 to 12 months. So, 3 times in a year. And then, if all the 3 MRD reports come negative, then that becomes very reassuring. Other scenario could be that the MRD is detected, there are disease cells still present, and therefore the report comes as ctDNA found, which means that there is minimal residual disease. After the initial treatments, what we did for that patient's particular stage, it could be a combination of surgery and or chemotherapy. In rectal cancer, it could also involve the use of radiation therapy. And once that has been done, then the MRD is still present. Then we decide additional treatments have to be done, or you enroll the patient in some clinical trial, or do a close follow up. What was predicted now, after 3 4 months, can become negative, and then again may continue to remain so after 9 to 12 months. So that guides us that how we are improving the cure rates by looking at the molecular at the minimal or the microscopic level. So, as per guidelines and recommendations, all of us practicing clinicians right now who are here in this podium and elsewhere in the country, therefore, incorporate MRD testing as per the guidelines and recommendations, being the guiding force so that all patients equally benefit from this test. So, truly, the management of colon cancer and rectal cancer is being revolutionized by the insights we get from such innovative tests and important tests like minimal residual disease detection. So, this is the current era where MRD is being practiced by all of us for that patient where it is deemed necessary by us and not by anybody's whim and fancy. And that helps us to improve patient outcomes uniformly in the country and across the world. In that way, I can tell you that our cure rates and the way we approach patients is at par with any other patient, be it in the US, in the UK, or Australia. Thank you so much.
That's so good to know, sir. Dr. Vaibhav, can you tell us that how can we address the cost challenge, the accessibility challenge of MRD testing? How can we make it more, affordable and accessible and acceptable?
Yeah, so there are many aspects to this question. First of all, if the tests are standardized and there is a lot of awareness amongst people, amongst the medical oncology colleagues, as well as the surgical oncology colleagues, that this test is important and now it's prime time to use it. So more the volumes, if more volumes will come in for the test, obviously the company, whoever it is, wherever the approvals are, if they get more volumes, then obviously the cost comes down drastically. That is the story everywhere. It's like once more and more patients are doctors are aware, first of all the doctors, the surgeons, the gastroenterologists, whoever are a stakeholder in a patient's treatment should be convinced about this thing, that this thing is there and this thing will actually add to the value to the patient care. And once we scale that up, this awareness as well as the MRD in routine practice, obviously the cost is going to come down. That has happened with everything which has been successful, starting straight away from the cytogenetics, the next gen sequencing tests on solid thing. The similar thing, this is a sophisticated technology. Obviously, right now the cost can come down as much. But yes, supply and demand is one thing. First of all, if more volumes come in, then automatically it will come down. Another thing is the technological advances. The technological advances which have been happening in this field, they play a major role in cutting down the cost. More sophisticated machinery, use of AI to refine things. So not only will it cut down the cost, it will also cut down the TAT as well. So that turnaround time for the, because all these things are very critical and crucial. So turnaround time has been least with these liquid biopsies because there is less of a hassle there in finding out the DNA and then subsequently doing the test. So these liquid things, liquid biopsy, MRD, these are actually faster than the next gen sequencing done on solid block. And uh, with more better technology, obviously the cost will be cut down and it will become more and more affordable as well as accessible. Another thing is, since it is a kind of a test which has been approved, now we're talking about the approved test and the not approved test. If these tests are approved and it has value, then certain government authorities, obviously, or maybe insurances, they might actually come into the play and they can actually, like it happens in US when the test is FDA approved, then obviously it is reimbursable. It is in insurance also now. An average in Indian after COVID, they do have a lot of sea change we have seen in the health insurance sector. Also, people are now taking more and more health insurance. They are aware. So these tests, if they are being completely reimbursed or completely covered under certain insurances, including in certain cases government schemes as well, if there is a provision for that, then obviously there will be widespread utilization and the cost challenge will be met.
Right. So insurance coverage and of course demand and supply that needs to be addressed. So I would like to ask each and every one of you. I'll start with Dr. Niti first. That what advancements are being made in MRD testing and what the future looks like.
Let me start by saying the future is very different from what it is right now. We not just have ctDNA information, but we have ctRNA information. We have TPs, we have exosomes. So way we are looking at tumor is becoming very different. And what we need to do is, as everybody mentioned, data integration. We have a lot of biomarkers. We have to integrate that data. We sometimes have small data. We have sometimes large clinical trials. Integrate that data and use it in clinical scenario, which can justify our stance by having probably a precedence or people who have done well in the past. Integrating that data, which requires a lot of AI and machine learning. And I think we are evolving. We are getting there. So it's not even future. It's actually now. And every day we are incorporating all these things more and more.
Yeah, it's now. So, Dr. Palanki, your message.
So I think uh, at this point of time, all of us realize that hope is the only thing stronger than fear. And investigations like this, various revolutions like this, be it in treatment or investigations, drive away the fear of the disease and make sure that our patients conquer the disease. It has been a battle to beat cancer, it's been a combat to conquer cancer, it's been a crusade to cancel cancer by authorities across the world for the past many centuries. And we are moving very fast forward now to make sure that we keep on curing more and more patients. So, from a situation of despair for stage 4 patients, we now talk about hope, and reality is that we're able to cure many of the stage 4 patients, and therefore we can do much better for the early stage patients, stage 1, 2, and 3, where we don't want the disease to come back. And that can happen when we attack the disease at its roots, which is the minimal residual disease level. And so the approach has become more individualized, the treatments have become more personalized, and on a case by case basis, we are able to see which test can be utilized and exploited to the maximal extent so that the goal of maximal efficacy with minimal toxicity is attained. And that therefore leads to a therapy which gets tailored to that particular patient and not a broad spectrum patient. One size does not fit all. That's what MRD has taught us. Thank you so much.
Right. Dr. Priya, how does the future or now looks like to you?
So now is confusing. Future is exciting. We have such a huge amount of data and information. We ourselves don't know how to interpret it. But the good thing it's there. So sooner or later we'll be there. So the good things are advancements are happening at multiple levels. We understand how the cancer is being caused, from the role of lifestyle to our own microbiome playing a role in causation. At the same time, also taking into account the hereditary factors. The simple things are making a big, enormous impact. And yes, the MRD will definitely help us to decide how to take the treatment forward. So, be it chemotherapies, better way of managing the side effects, the immunotherapies. I think yes, the future is exciting.
And Dr. Vaibhav?
Yeah, my take here would be with every new thing, with every new technology, with every new breakthrough in the treatment as well as diagnosis, we are getting one step closer to the ultimate goal. And the ultimate goal, to my mind, being a medical oncologist, I routinely deal with most of the time in my office, I deal with stage 4 cancers. Being in KDH, it's a high volume center in Mumbai where a lot of patients come across from different places, and the stage 4 was a death sentence since I think 20 years back, 15 years back. We are progressing day by day. First chemo, then target, then immuno, then the combinations, and these tests like MRD. That before the disease becomes stage 4 on PET scan, it's evident you catch it, and then not only that, you get some molecular insights through ctDNA testing, and then you can attack it even before it comes. So we are approaching closer and closer to that goal. That is the holy grail of medical oncology, to cure each and every one, to cure each and every cancer. Stage 4 cancers, from being a death sentence or very, very highly lethal disease, it has now already converted into a chronic disease. So, what we do is we just cut down the disease burden and decrease the disease burden. And the excellent test here to find out is MRD. If MRD is negligible or zero, then you are confident that your strategy is working to convert all these cancers into a chronic disease, treat them like a diabetes and a hypertension. What happens if a diabetic is not responding to one drug? You give combinations. What happens in hypertension? Same thing applies here. It's just that our science is new, and this problem is a very complex problem as compared to the other diseases. There are many elements to it, but the key here is with such tests and the new drugs based on this. So MRD, yes, it will get refined, and ultimately it will change the face of medical oncology as cancer as a whole. Thank you.
Right. Right. And since we know that March is a colorectal cancer awareness month, so Dr. Niti, any message which you would like to give to our viewers to raise awareness and how to encourage prevention?
Prevention starts with lifestyle modification. And again, everybody stated that cancer is a lifestyle disease. Changing your dietary patterns, changing your physical activity levels to a more active lifestyle, diet which is plant-based diet, rich in fruits and vegetables, red meat wherever you can avoid, modify the content of fat you're taking, the type of fats you're taking, and of course having good body weight with BMI being low, being aware of yourself, going to specialist at regular time, understanding the symptoms, doing at least regular screening in colorectal, which is just a stool test, just looking for stool or cut blood. If you have a family history which points towards a colon or rectal cancer in the family, then get your history screened. Whether you have a familial colorectal cancer or heritable colorectal cancer, which requires regular screening in the form of colonoscopy or sigmoidoscopy at a certain interval, these all things to be understood. Whether you require a blood test to find out you are at risk of colorectal cancer, these are some things which we all need to know about, read about, and discuss with your oncologist.
Dr. Priya, your message for prevention and awareness.
See, the most important thing is people should understand that the real awareness starts from being health aware. Okay, so you become health aware and you become cancer aware. And most importantly, don't neglect what your body is trying to tell you. If there are any new onset symptoms, and it's especially after the age of 40 years or 50 years, if we are not doing colonoscopies, we are not doing screenings. Okay, do consult your doctor. Okay, it's very important that we find the cancers in time and we hit it hard.
Right. Dr. Vaibhav.
Yeah, cancer is curable if detected early. That is the message since ages we have been propagating, and every minute detail, any subtle changes in the bowel habits, as well as if someone notices bleeding per rectum, if someone, because this is a thing, it is not happening overnight. Cancer takes time to form. Cancer takes time to become symptomatic. So screening is an excellent tool, which is there. There are guidelines for that, age-related guidelines as well as familial history-related guidelines. These need to be followed. One should be aware of them. Second, yes, healthy lifestyle does help in preventing bulk of environmental cancers. And building on that, not only would you cut down the cost of one this single disease, you can actually cut down the cost of all other chronic diseases as well. If you maintain a healthy lifestyle, if you maintain exercise habits and a body weight, which is and also the diet, all these things if you work on, because remember at the end of the day we are oncologists, we are focused on cancer. Today's session is only on colon cancer, but this thing is more holistic. If you adopt a healthy lifestyle, then cancer is not the only thing which kills. Obviously lot of lot of morbidity and mortality occurs because of other non-communicable diseases as well, which are lifestyle related. So that's why we should start from the doctors themselves should adopt a healthy lifestyle, propagate that in their dealings with the patient, always talking about and emphasizing in that it is the biggest tool and the best way forward to prevent. And even if it is occurring, then detect. Be aware of your body. Be aware of the bowel habits and all for pertaining to colorectal cancer, and get yourself screened or checked by your doctor at the early symptom.
Right, sir. So today's discussion has truly highlighted the role of MRD testing in colorectal cancer management. I thank you all for joining us today for this insightful discussion. Thank you very much.
Thank you.
Thank you.
Thanks so much.